Okay, there's usually several questions on a test about respiratory volumes and capacities. Um, I need you to know what the definition of each of the volumes is. Generally speaking, I don't need you to know the numbers. This one, this first respiratory volume, which is tidal volume, and that is the amount of air that we breathe in and out at rest, moves in and out like the tide, and that's about 500 milliliters. And that much you should know. You should know that that bit of air is right around 500 milliliters. Now, there are things that will affect our total capacity, including tidal volume. Um, and those include things associated with a person's size. So, a large person is going to have a larger lung capacity. Sex, men tend to have a larger lung capacity. Age, as we get older, our tissues stiffen up a little bit and we have a decrease in capacity. And physical condition. The better shape you are in, the greater your lung capacity. Now, some of the terms you should know. There is an amount of air that I can breathe in above and beyond my normal resting volume. And that is the inspiratory reserve volume. That's the amount that I can take in when above that when I take in a deep, deep breath. And it's usually between 2 and 3 liters. We also have expiratory reserve volume. And that's the amount that I can force out of my lungs if I have to beyond what I normally breathe out. And that's about 1.2 liters. There's also a little bit of volume that's left in the lungs no matter what. I can force as much air out as I want to. I'm still going to have about 1,200 milliliters left. And that's not going to go away unless you get run over by a steamroller. You have had that residual volume in your lungs ever since you took your first breath. Now, vital capacity is a measure of the total amount of air that we can take in and blow out in one deep breath. So it includes tidal volume plus inspiratory reserve plus expiratory reserve. And that amount actually is somewhere between 5 and 6 liters total. There's also a little bit of air, which is called dead space. Now, remember we talked about that gas exchange only occurs in the alveoli. Well, we have all of these tubes that are the conducting tubes. We have the trachea, we have the bronchi, we have the bronchioles, and so forth, and no gas exchange that occurs there. So the air that we breathe in that fills those areas is considered dead space, and that's about 150 milliliters. There's the functional volume, which is what's left of that 500 milliliters, and that's the 350 that actually makes it into the lungs. Now, we have ways of measuring just what an individual's volumes is. There is something called a spirometer, and so you can test and look at all of these different respiratory volumes. So, total vital capacity, typically, when we say we've got inspiratory reserve, tidal volume, and expiratory reserve, it's 4,800 milliliters. The fact is that a bigger person, bigger chest, is going to have maybe a higher volume. My own measured volume was 6,200 milliliters. It just depends. Total lung capacity is all of those plus the residual volume that's left. So you should know what all of these individual volumes are: inspiratory reserve, tidal, expiratory, and residual volume in terms of their definitions. And you should know that vital capacity is inspiratory, tidal volume, and expiratory. The two actual numerical volumes I want you to know is that tidal volume is about 500 milliliters, and vital capacity tends to be around 5 liters. You don't need to know the specific amounts of the inspiratory reserve or the expiratory reserve. Now, external respiration, we've already talked about, so I'm actually going to just blast through this one. Again, it's oxygen gets loaded into blood, carbon dioxide gets offloaded. Great. We've already said that, so we're just going to move on. And again, we've seen this graphic of oxygen going into the blood, carbon dioxide out. Internal respiration, just to make clear, understand that internal respiration is the exchange of gases between blood and body cells. And it is the opposite of what's happening in the lungs, because we now have more oxygen in the blood than in the tissues, and more carbon dioxide in the tissues than in the blood. Again, a graphic just to show the general process. There are several things that regulate how much we breathe, the rate and the volume. There are neural centers in the medulla and the pons that pick up or get signals from the hypothalamus based on oxygen concentration and activity levels and other things. There are some terms for different respiratory rates, and I would like you to know what all of these terms are. So a normal respiratory rate is eupnea. And you should know eupnea. And it's about 12 to 15 breaths a minute. It can be lower. It can be 10. Just depends, again, on the person's physical conditioning. Hyperpnea is an increased respiratory rate, and it's usually due to an extra oxygen need. Now, it's not necessary that you're hyperventilating, it's just that you are breathing faster because of physical activity. Dyspnea is when you are having painful or difficult breathing. Apnea is a temporary cessation of breathing, so you stop for a little bit. Respiratory rest is when you stop breathing altogether. So apnea is sometimes followed by respiratory arrest. If that happens, then usually cardiac arrest follows shortly thereafter. Now, hyperventilation and hypoventilation. These are situations where we are breathing faster or slower than our 12 to 15. Hyperventilation, we're going to breathe a little faster if we have more carbon dioxide in our blood. So we want to blow off more carbon dioxide. Our blood is acidotic when we have a higher level of carbon dioxide. So we increase breathing. It becomes deeper, more rapid, blows off the carbon dioxide, and restores our normal blood pH. Hypoventilation, the blood becomes alkaline, or you have alkalosis. And to counter that, we get a slower, shallow breathing, which allows carbon dioxide to build up, increasing the acidity. Now, carbon dioxide is a potent acidifier. When you think about the acids that are in colas, well, the reason they're acidic is because they are carbonated. Now, there are some non-neural factors as well that influence it. If you get overly warm, you're going to breathe faster. We pant still. Physical exercise just increases the demand of the body for oxygen, so you're going to increase your respiratory rate. When we talk, we regulate our breathing a lot differently. I'm probably not doing the 10 to 15 breaths a minute. I'm doing probably more like 5 or 6, because I'm taking these breaths and I'm talking for extended periods of time. Coughing, sneezing, those are also going to alter your respiratory rate. You can consciously choose not to breathe. You're not going to be able to hold your breath till you die or anything like that, because as soon as you lose consciousness, then the neural factors will take back over and force you to breathe. There are emotional factors as well. If you are frightened, you're going to hold your breath. If I thought that Jason Voorhees was in the house, I would not want him to hear me breathing. And whether we're aware of it or not, we hold our breath in situations like that. Now, the two main things that our body reads to decide how we want to, how frequently or deeply we want to read, are chemical factors. And the CO2 level is the most important stimulus. We need to get rid of the carbon dioxide. Increased levels of carbon dioxide result in an acidic pH, and that's going to increase the rate and depth of breathing. We also have oxygen levels, and there are chemoreceptors in the aorta and in the carotid arteries that evaluate oxygen levels and will increase respiratory rate as needed to increase the oxygen levels. These are parts of our body that need to get a lot of oxygen, and so if the brain is not sufficiently oxygenated, it will result in a increased breathing rate. Now, there are a few things that get in the way of good respiration. There are some chronic obstructive pulmonary diseases, and there are two major ones, chronic bronchitis and emphysema. And these are the major causes of death and disability in the United States, and they are tied very much to smoking. Patients almost always have a history of smoking who have had emphysema or chronic bronchitis. They have labored breathing. It's difficult, becomes more severe. They have coughing, frequently get pulmonary infections. Most of the victims are hypoxic. That is, they just don't have enough oxygen in their tissues. They are retaining more carbon dioxide, and so they have respiratory acidosis. And what happens there is CO2 levels that would make you and I breathe, they've adapted to. And so they just have higher CO2 levels. In fact, this can cause problems if you take someone who has emphysema or chronic bronchitis and you put them on a 100% oxygen mask, you actually remove the stimulus for them to breathe, and they may stop breathing. It's temporary, but they will do that. Those people who have these conditions will ultimately end up dying from respiratory failure. Now, chronic bronchitis, the first of these, the mucosa just gets inflamed and it constricts airflow. The mucus production gets too high, so you start getting pooled mucus, which impairs gas exchange because you have to have this exchange through this thicker material now. You get a higher risk of lung infections because there's fluid there that the material, the bacteria can live upon. And pneumonia is very common. One term that is used, and you don't have to remember this, but these people are sometimes referred to as blue bloaters because they are hypoxic, their skin's a little bit blue, and they tend to retain fluids, so they look a little bit bloated. Now, we're going to stop here on this presentation, and we will proceed to and finish up with our last presentation here in just a moment.